Thank you, Planning Committee and Dr. Khan for inviting me today to speak on hypertension, a topic very dear to me. I'm going to speak about what's new and what's old. These are my conflicts of interest, not really much. I just wanted to stress that we all deal with hypertension, and we know that there's a lot of morbidity and mortality that are affected as a result, and leading to lots of end organ damage. I'm not going to spend a lot of time on this, but we're all aware that there's cardiac effects, renal effects, effects on eye and brain effects, and they can be all quite deleterious, and ultimately many of them can lead to premature death. So it is really important to target blood pressure and to reduce the complications that are often preventable. So this is just a slide to show that there is so much we can do about hypertension control. It's not treated appropriately in quite a big percentage of our population. But the good news is that even small reductions in blood pressure can lead to significant reductions in major cardiovascular disease, stroke, congestive heart failure, ischemic heart disease, and cardiovascular deaths. So this is really good news. So the bang for the buck is really, really high to getting blood pressure down. And this is well known, and this is long-standing data with that has been reproducible for quite some time. The first thing is that in order to make the diagnosis of hypertension and to monitor hypertension and to make sure we're targeting appropriately, it's got to be done properly. And there's a nice tool or a pictogram here from Hypertension Canada, which I work with very closely, showing how to actually do blood pressure. And I actually put this up in my office. And if you go on to hypertension.ca, you can print this out and actually put it in your office to give you a reminder that if you don't do blood pressure properly, you may actually underdiagnose, overdiagnose, and not treat your patient appropriately that's sitting in front of you. And this is, I can't stress this more enough, blood pressure monitoring measurements have to be done very, very accurately to get the true bang for the buck in terms of treatment and monitoring, both in the physician's office or the healthcare provider's office and at home, which is often done by patients these days because of the pandemic. And there is some good data that home blood pressure monitoring or out-of-office blood pressure monitoring is much more accurate and better correlated with outcomes, which I'll get into in just a bit. So the first point that I wanted to talk about is the validity of office blood pressure measurements and out-of-office blood pressure measurements. I'll start off with office blood pressure measurements, and there are some acronyms. So AOBP is automated office blood pressure monitoring, where we're not using a sphygmomanometer or staying in the office while the patient's there to monitor or measure their blood pressure. This is due to from an automated device, and the healthcare provider leaves the room to avoid the white coat effect and to get a more accurate blood pressure. This is the preferred method for in-office blood pressure monitoring. The second one is you're actually sitting in front of the patient and checking the blood pressure in front of them, which is not as accurate, especially if you're using mercury. In fact, mercury is outdated and should not be used. But even if you're using oscillometric, it's still not as accurate because you may overdiagnose hypertension due to the white coat effect. Then what's really, really new and important is out-of-office blood pressure assessment, which there are two types. There is the ambulatory blood pressure monitoring, ABPM, which is unfortunately not covered by OHIP at this time, at least in our province in Ontario. This is something that's put on the patient, and they get a 24-hour monitor. It's just sort of like a Holter monitor, but monitors blood pressure and pulse and gives you lots of data, daytime blood pressures, nighttime blood pressures, and also looks at the dip of the blood pressure, which often occurs overnight, which is really, really important and is correlated with cardiovascular and renal outcomes. So this is ideal, but cannot totally practical and feasible due to cost and convenience and other issues. The second, which is quite good, pretty close to ABPM, is home blood pressure monitoring with an approved device where the patient is taught how to monitor blood pressure at home with several measurements for 7 days at least before seeing the healthcare provider, but should be doing it routinely thereafter anyways for home, for personal awareness and feedback and change of behavior. And this is easily done. And there's there's lots of information on Hypertension Canada website to show the patient how to do this, as long as the blood pressure device is accurate and approved by Hypertension Canada. So I just wanted to stress that this is probably the best way to monitor blood pressure, either ambulatory blood pressure monitoring or home blood pressure monitoring. So what does out-of-office blood pressure monitoring afford? offer better versus office blood pressure monitoring? Well, first of all, it will avoid the effects of white coat hypertension, which we are all aware of, and something called mass hypertension. This is when the blood pressure is okay in the healthcare provider's office, but higher actually at home, which is interesting because you would think that should not happen, but there's many reasons for that: stress at home, other factors. Now, we do know that mass hypertension does carry a worse prognosis, but what we don't know up till now, which is being studied further, is by treating mass hypertension, do we improve outcomes? And that's a topic for a later date, but I just wanted to mention that. 24-hour ABPM has a better predictive ability than office blood pressure monitoring for cardiovascular events. That's why it's more useful in terms of accuracy and outcome prediction. And home blood pressure monitoring is also more predictive in terms of events compared to office blood pressure monitoring. So the bottom line is out-of-office blood pressure monitoring is more accurate and has a better correlation with cardiovascular and renal events compared to office blood pressure monitoring. And it's much easier to do home blood pressure monitoring due to the availability and the feasibility compared to 24-hour ABPM. So again, this is just a slide showing the correlation between out-of-office, which is more correlated with events compared to office blood pressure monitoring. So whether you look at left ventricular hypertrophy, albumin excretion ratio, systolic or diastolic blood pressure, this all favors home blood pressure or ambulatory blood pressure monitoring in terms of correlation with cardiovascular events. What about automated office blood pressure monitoring? So this is actually in the office when you step out and check their blood pressure compared to sitting in front of the patient. So again, very similar to the previous data that I've shown, although this is in office but automated, it has a better correlation again to cardiovascular outcomes and very similar to actually ABPM for urine albumin creatinine ratio excretion, and also carotid intermedial thickness, CIMT, compared to office blood pressure monitoring when the patient is in front of the healthcare provider. So again, it also mitigates white coat effect, as I mentioned earlier on. So the best is out of office. The second best in terms of accuracy and predict outcomes is office, but automated office blood pressure monitoring. And the least accurate is actually when you're sitting in front of the patient and doing their blood pressures. So there's really a paradigm shift in terms of diagnosing and monitoring blood pressure, which should be ideally out of office. And if that's not feasible, in office with automated office blood pressure monitoring. So that's why we've changed our approach to diagnosing and monitoring blood pressure. And I'm not going to go through this whole table because many of you are aware of this. The bottom line is if you suspect hypertension, often it's done in the office. If it's really, really high, if it's more than 180 over 110 and there are no other confounding factors, you probably don't need to go on further. This probably makes the diagnosis of hypertension as long as it's done properly and accurately with the right technique of measuring blood pressure. The second question you want to ask is if you have diabetes, because the targets are different. And then the key thing is that you want to do multiple measurements, and ideally speaking, the diagnosis should be made by out-of-office blood pressure monitoring, depending on the targets, whether you have diabetes or not. And once you make the diagnosis after multiple readings, then therapy can be indicated depending on the overall global risk profile. So it's just not about the blood pressure; it's all about the risk factors. Do they have end organ damage? And you can use all that data to make a decision whether you're going to treat them with antihypertensive agents to decrease their outcomes in terms of cardiovascular and renal events. So we have to look at age and risk factors and comorbidities, as I mentioned, just to reiterate, to make the final decision whether this is true bill hypertension and whether they deserve intervention at this time. Even if they don't, you're still going to stress lifestyle modifications and follow them along. I'm going to shift over to SPRINT study, which was a large randomized controlled trial looking at lower targets in high-risk patients, which has not been adopted fully yet because we know that guidelines take a while to adopt. But the bottom line here is usually we're targeting blood pressure targets for most people, unless they're diabetic, less than 140 in the office and less than 135 over 85 outside of the office. But this actually looked at a target of less than 120. And what was the inclusion criteria? Well, they had to be over 50 with blood pressure systolic levels above 130, and they had to have either clinical or subclinical cardiovascular disease or chronic kidney disease, defined by what I put up on the slide, or an estimated 10-year global CV risk of more than 15%, or aged greater than 75 years old. So what was the primary outcome? The primary outcome was a composite of acute coronary syndrome, heart failure, stroke, and cardiovascular death. And as you can see, with intensive treatment of a target blood pressure less than 120, the intensive treatment did much better in terms of the composite outcome. And that being said, keep in mind that the monitoring and the diagnosis was based on out-of-office blood pressure monitoring here. As you can see from here, it was all based on automated, either in the office with automated office blood pressure monitoring rather than just sitting in front of the patient. So I just wanted to correct that. It was automated office blood pressure monitoring. And the number needed to treat to prevent an event was 61, which is quite good compared to many of the other treatments we use in medicine these days. With any therapy, there always comes some harm, but overall the benefit will outweigh the harm for the most part. As you can see, there was a significant reduction in the primary composite outcome, which I mentioned already, but even heart failure reduction was there, cardiovascular mortality, there was a reduction, and there was also a reduction in all-cause mortality. But what was some of the harm? There was some hypotension, some syncope, electrolyte abnormalities, and acute kidney injury. But as you can see, most of the harm was quite less than the benefit. So again, it is case by case. You want to target your individual and approach this as a personalized medicine. But the bottom line is in high-risk patients, the SPRINT study does apply to going for a target of less than 120 if you use automated office blood pressure monitoring. So based on the SPRINT, who does this not apply to? Well, there's very limited evidence if they have heart failure, especially with low ejection fraction or a recent MI, and if they have an indication for a beta blocker, but they're not receiving it, and of course the frail institutionalized elderly. And in terms of inconclusive evidence, we don't have data that this trial supports patients with diabetes mellitus or a prior stroke or with significant chronic kidney disease, with an EGFR less than 20. And some contraindications, those patients who are unwilling to adhere to multiple medications, those who have standing blood pressures of systolic less than 110 because of the risk of orthostasis in presyncope and syncope, and those who have an inability to measure their systolic blood pressure accurately, and if they have any other causes of hypertension, which are secondary causes, whether it's hyperaldosteronism or pheochromocytoma or renal artery stenosis, etc. So based on the recent evidence in high-risk patients and diabetes, we have some new targets. So for the high-risk patient, as I mentioned earlier, like the SPRINT patient, the threshold for initiation is more than 130 systolic. We don't have the diastolic data, but the systolic blood pressure target should be less than 120 to reduce reduce the composite outcomes. For diabetes, we haven't changed anything. It's 130/80, both for the threshold and for the target. And for the moderate to high risk, which is most of our patients with some end organ damage or multiple CV risk factors, the in-office target blood pressure initiation is more than 140/90, but the blood pressure target in terms of the lowering should be less than 140/90. And then again, keep in mind, this is for office blood pressure targets and initiation. If it's done as an outpatient with out of office blood pressure readings, the targets and initiation should be at 135/85 unless they have diabetes, again, which should be lower to 130/80. And if they're very low risk with no end organ damage, someone who's very young without any risk factors, the initiation should be at 160/100, and the target should be 140/90 for inpatient. But again, these are for very low risk patients, which are often seen in primary care and not often in specialty or tertiary care centers. And just keep in mind, most of these targets and initiations are based on automated office blood pressure monitoring or just office blood pressure monitoring results. So cut back, you want to reduce it by 5 millimeter mercury for out of office targets and initiation, which is usually for most of our patients at 135/85, unless they have diabetes, which is 130/80. And keep in mind that we always want to include non-pharmacological measures to enhance our pharmacological therapy to achieve a better benefit in terms of blood pressure reduction. I'm going to switch over to the diuretic aspect of things now. A lot of us do use diuretics. I'm talking about thiazide or thiazide-like diuretics for blood pressure control because they're very effective. But there's always a debate, which is the best diuretic? And I'm going to present some evidence, try to convince you that all diuretics, all thiazide diuretics are not the same. And the best evidence that we have actually for reduction in coronary events and all-cause mortality is with the thiazide-like diuretics, whether it's chlorothalidone or indipamide versus hydrochlorothiazide. So hydrochlorothiazide is not as effective in terms of reducing these events. And number two, it's not as effective at reducing blood pressure compared to chlorothalidone and indipamide, as I'm showing on this slide here. So if you're going to choose a diuretic, a thiazide-like diuretic or a thiazide diuretic, the two choices that will be optimal in terms of reducing outcomes of blood pressure would be chlorothalidone or indipamide, and we should be swaying away from hydrochlorothiazide until we get further evidence to disprove this. So again, I've already talked about reduction in blood pressure, and what I'm showing you here is that when you compare hydrochlorothiazide to chlorothalidone, albeit this being a small study, the reduction in both systolic blood pressure and diastolic blood pressure in ambulatory blood pressure monitoring is much more significant with chlorothalidone compared to hydrochlorothiazide, which was shown in this trial here back a few years ago. And as I mentioned, this was out-of-office ambulatory blood pressure monitoring with 24-hour blood pressure monitor. Okay, we've talked about just the importance of hypertension, which diuretic should we use, does it matter, the role of out-of-office blood pressure monitoring compared to in-office blood pressure monitoring and the advantages and the cons. We're going to switch over now to another important topic or issue, which is what about refractory or resistant hypertension? First, we have to define what this is. So this is when your blood pressure is over target, when you're on 3 or more approved optimal dose therapies for hypertension, and you're doing the blood pressure properly, and you're already on a diuretic, and usually a RAS blocker or a hydropyridine calcium channel blocker, such as amlodipine or nifedipine or felodipine. And the RAS blocker I'm talking about are either ACE inhibitors or angiotensin receptor blockers. And you also have to rule out, of course, adherence issues, the white coat effect. That's why out-of-office blood pressure monitoring is important, and ruling out secondary causes of hypertension, endocrine causes, renal causes, cardiac. And I put in drugs and toxins in bold because unless we ask about this, we're never going to get this, especially things like alcohol and supplements and herbs, and in particular, non-steroidal anti-inflammatories that patient may not be telling you about that they're using for pain. So this is really, really important to ask about anisin and naproxen, which often many of these things are found over the counter. And once again, accurate BP measurement is critical before going on to embarking on a road to defining or establishing resistant or refractory hypertension. So I wanted to present this important study called the Pathway 2 study, which compared spironolactone on top of routine therapy comprising of RAS blockade, dihydropyridine calcium channel blocker, and a thiazide or thiazide-like diuretic. That was already on board, and the comparison with spironolactone was versus placebo, versus bisoprolol, versus doxazosin, and it was fairly balanced study. There were about 300 patients who were followed at the end, and the bottom line is that if you look at the overall results, that spironolactone compared to bisoprolol, compared to placebo, compared to alpha blockade had a much more pronounced effect on blood pressure reduction compared to the placebo, bisoprolol, and alpha blockade. So this is really, really good news, and hopefully it'll convince many of you that we should be using spironolactone earlier on after we got them on standard therapy, once we ruled out secondary hypertension, because the blood pressure reduction is significantly more compared to these other therapies that we often go to, such as beta blockers, which are not very powerful in terms of antihypertensive effects. So I just wanted to plug this in for spironolactone. I use a lot of it, not because of just because I do, but we have good evidence now based on the Pathway 2 study and other smaller studies that have supported the use of spironolactone, as long as we do monitor their renal function and their potassium, because these things are important to monitor when you put them on spironolactone, and you often don't need very, very high doses. So we can't just walk away. We need to monitor their renal function and their potassium and the small effect of gynecomastia in men. So first-line therapy, again, I'm not going to go into compelling indications because that'd be a whole different presentation, but without any other compelling indications, for most people, the office blood pressure target should be less than 140/90, and if they have out-of-office monitoring, less than 134/85. And then depending on their risks and so on, you can choose from any of these therapies that I've listed at the bottom. And for the thiazide like, preferably indipamide or chlorothalidone. And if they're out of target more than you would like, then there is good data to use actually a single pill combination of therapies that are proven. There's a Stitch study that showed the earlier you get them on combo therapy, you get them to blood pressure reductions faster, and you may also improve cardiovascular and renal outcomes. So that's really important to know. We often try to maximize a dose of a therapy, but we have good data with many chronic diseases that by combining low dose therapies of two different pharmacological agents, we get better effects in terms of efficacy and in fact, even less side effects with this therapy. And patients tolerate them quite well. And we do have many single pill combination therapies on board in our system at present. So again, I've already talked about this, but I wanted to emphasize also with single pill combination therapy, there's also more adherence versus isolated therapies. And I've already talked about blood pressure control and decreasing cardiovascular events. We can't forget about health behaviors. As you can see, pharmacology is important, but we can't forget about non-pharmacological measures such as diet and weight control and reduction in sodium and alcohol and the famous DASH diet, which is sort of the Mediterranean diet. And this can be extrapolated to any culture, actually. It doesn't have to be, you don't have to be from the Mediterranean. So if you look at all of these interventions, they don't have an additive effect, but they actually often have a synergistic effect on reducing both systolic and diastolic blood pressure, especially the DASH diet. It's quite impressive. The systolic blood pressure goes down by roughly 11 and the diastolic by 5. So again, drug therapy with non-pharmacological therapy is not only additive, but it's actually synergistic. So very important to keep in mind. So I'm almost done here, and hopefully we'll have time for questions. There are some key take-home messages that I did want to share with the crowd here. So number one, out-of-office measurements, whether it's 24-hour ABPM or home blood pressure monitoring, is much more accurate than in-office blood pressure monitoring. And if we only have in-office blood pressure monitoring, it should be automated office blood pressure monitoring where the healthcare provider steps out of the room. And this is better correlated with blood pressure outcomes such as cardiovascular and renal outcomes. Number two, all thiazide, all diuretics are not the same. Thiazide-like diuretics, in particular chlorothalidone and indipamide, are more efficacious and have better cardiovascular outcomes compared to hydrochlorothiazide. Number three, single pill combinations have better adherence and better blood pressure reduction. And we have many of these in our system right now, especially with once daily formulations. And number four, with refractory or resistant true hypertension, once you ruled out improper technique and secondary hypertension, that spironolactone being very cheap, easily once daily mineralocorticoid receptor antagonist works very well in terms of blood pressure reduction when you already have them on 2 or 3 appropriately dosed standard therapies. And lastly, for the high-risk patients that we often do see who have a high cardiovascular risk, consider targeting a systolic blood pressure less than 120 based on the SPRINT study to improve the composite outcomes of cardiovascular disease and mortality. Thank you very much.